Scottish Planner live. We're running 10 sessions over the course of 1 week of short online sessions as a replacement to what used to be the RTPI Scotland conference. For the whole week, we have a perspective around what planning and planners can be doing to deliver the healthy places that we need across Scotland. That, given what we've all been through with COVID, looking at a new normal, the fact that we've all looked more closely at the places in which we live, and we've all taken part in the biggest example of prevention and behaviour change in order to keep us all well that I think many of us have ever experienced. So through the course of this week, we'll be looking at what role planning can have in those interventions and preventative measures to keep people well. And for myself and my own background, the biggest reason for that is that in Scotland, we do not have a great health record. Some are faring, and numbers and health is faring very well, but we have inequalities in that across Western Europe. We do not fare well, and life expectancy differences across Scotland vary between 22 and 26 years. It's an immense issue. It's something that planning's been working on for years. My name's Irene Beautyman. I'm the 2020 convener of the RTPI in Scotland, and I'm chairing the sessions this week. But I also, very close to my heart in the conversations we're having today, I work at the Improvement Service, which is the organisation that helps local government in delivering on our national outcomes. And I'm also part of my time on a secondment to Public Health Scotland, again looking at the role of place and place-based approaches into delivering that, specifically around spatial planning, MPF4, and how we move forward with that. So in a moment I'll introduce our main speakers today, because what we're looking to do really is to bring together what happens in a place and look at the kind of processes of how we work more in partnership. When we think of any place, I think it's important to highlight now, we talk a lot about place, but I'm not sure that we're always very clear on what we mean. We mean all the characteristics of a place, and planning is very heavily involved in that physical environment and what we shape and what we develop, but we're always aware that that's because of the impact it has on people, on the communities. But then it also impacts on the economy, who's investing, where people are working. So it's all of those aspects that come together in a place, and that's always going to be different in every place that you look at. And for planning and for our week ahead, it's very much looking at what are the intended consequences of what we do, but also what are the unintended consequences that we can end up having a country that does suffer such inequalities, that also has child poverty, that has homelessness. Nobody planned, nobody legislated for this. These things were planned and legislated for with a very good purpose, but there were unintended consequences that have led to where we are today. So what role does planning have as we move forward and look to an all systems approach to actually improving the circumstances when it comes to health? And that's health of people, and that's health of planet as well. And when we pull those together, for myself, that's where that coins that term well-being. So I'm delighted that I'm joined today to have a conversation about that situation in Scotland with its health and its well-being by leaders really in public health and in local government. And the conversation will be around where do we share that ambition and how do we come together around that. I'll be joined by Claire Sweeney, who is the Director of Place and Wellbeing at Public Health Scotland. And Claire is responsible for place-based approaches to improve the health and well-being of Scotland. And that's at the same time as being rather busy in Public Health Scotland with a pandemic at the moment. We'll also be joined by Angela Scott, who's Chief Executive at Aberdeen City Council, who has that insight into the role of not just planning and planning authorities, but into the whole local government insight, and can share that with us. But I know from my conversations with her that both Claire and Angela really do get what place is and the impact that place has on our health and well-being. And I'm fully aware that Angela was involved within the reform, the public health reform as that was ongoing, and right down into that nitty-gritty of spatial planning, working alongside the head of planning that we're all aware of Gail Beattie up in Aberdeen as well. So two informed and experienced speakers today that I'm delighted we can have a conversation with for their insight. There is a Q&A after each have shared their thoughts, and I urge you to begin as soon as possible inputting any questions that you have there. We generally find that we run away with it with time and don't always have the time to ask all of those questions. And as chair, I get to choose which ones we're pulling out if there's a lot, so forgive me if I don't choose yours. So, without any further ado then, I think what I'll do is I shall ask Claire Sweeney if she could come online. Hi, Claire. And if you could just give us your short introduction and sharing of thoughts on the role of Public Health Scotland and what Scotland and planning can be doing to address the health priorities that aren't just sitting there, I know, for Public Health Scotland, but for all of Scotland to deliver upon. I'll pass over to you, Claire.
Excellent. Thanks, Irene. And thanks very much for the opportunity to speak to you all today. It's a great shame we can't all meet in person. I always feel that most acutely that's a real shame, the biggest shame about the pandemic, I think, in terms of sessions like this. A great opportunity to come and talk to you about the approach we're taking in what is still a very new organisation, Public Health Scotland. I'm going to talk to you a little bit about our new strategy and our approach, which has been developed in consultation with many folk across Scotland. But it's also just fantastic to be able to talk about the future rather than what's happening this week or in the next hour even, but certainly over the weekends, as things are hugely challenging at the moment, which I know you're all very familiar with. So thank you. It wouldn't be a public health presentation if I didn't start off by setting out some of the challenges that we all face in Scotland. And of course, many of these are global challenges, but Irene touched on a couple that are particularly pertinent to Scotland, which is the relatively poor life expectancy and rising and widening health inequalities, which are clearly at the heart of the purpose of establishing Public Health Scotland. So it is no mean feat that we've been established to try and address those, but particularly given we're dealing with the pandemic at the moment. I'm sure many of you will be very familiar with Scotland's public health priorities, and Place clearly has a very strong representation within those overall priorities. It signals just how important Place is to achieving an improvement in public health across the board. And Place indeed is a huge focus for us in Public Health Scotland. What I would say, though, is that these public health priorities are Scotland's, they are everybody's. And one of the side benefits, I guess, of the pandemic is that everybody is talking about public health a lot more. And I think there's a lot more awareness about what public health means for everybody. We've all got a part to play in this. It is absolutely not something that one organisation can take forward on their own. It, of course, is particularly important to local government because a lot of the determinants of health and health inequalities actually sit within the sphere of local government. So for us, looking ahead, a big focus is going to be on how we work with our local government partners and, of course, other partners across the public sector and beyond. The priorities match so many LOIP priorities as well, and local development plans need to take account of those LOIP priorities. So there's good read across, and I think basically we have the infrastructure to make this work. That doesn't make it any easier to happen. So we all do have an onus on us to work in partnership to try and achieve these priorities. I wanted to say a little bit about why Place is a public health priority, and I'm hoping that with the audience today you don't take very much persuasion on this point. And as I've said, Scotland does have some of the worst outcomes, and we know there's plenty of evidence to show that those people living in the most deprived areas have the worst outcomes, and their environmental conditions in terms of their living environment are not the greatest in some cases. And of course, living in a great place is fundamental to having good health. Lots and lots of evidence from our organisation and others on that score. So we know that better places make for better health. So it's in all of our interests to start thinking about public health in terms of place. And it's something that we will be doing as part of our overall strategic plan. You as a profession have a huge impact to play here, and we really, really do want to work with you to see how we can improve that. My colleague Matt Lowther, who is here, who I know that many of you will be familiar with Matt's work, and will be a really important strand of our work for you to be engaged in. Really important that we get that connection between health and planning, which has not always been where it might have been in the past. This is a real opportunity to step that up. So just a very quick bit on our strategic plan, which is actually due to be published this week. So this is kind of hot off the press. Some of you might have seen a draft plan. This is the final version. And we are absolutely focused on a Scotland where everybody thrives. That will be the focus of everybody in our organisation, along with our partners. We've not had the easiest of starts, that is fair to say. The impact of COVID on our work has been absolutely immense and continues to be so. But the day job, if I can say that, doesn't go away. There is so much more we need to be doing beyond COVID, and we are absolutely focused on that task. The plan, you will see, talks as much about how we will do this as what we will do, because genuine collaboration and doing things differently and innovation with our partners is at the heart of doing this well. The days of one organisation sitting in the corner and thinking about particular theoretical approaches and the like has gone. This is a very practical plan, and you will be key partners in helping us to achieve the vision that we have of a Scotland where everybody thrives. So the public health priorities for Scotland belong to everybody, but we cannot do everything in Public Health Scotland. So we have been clear in the strategy about the areas that will be an initial priority for us. And some of those will be no surprise to you, I'm sure. COVID absolutely merits a mention. It will affect our work for the longest time. That is not just the emergency response around COVID, but that is the impact that COVID is having long term on all of our communities. And of course, I mean by that the economic impact as much as anything else. Mental wellbeing, something that I know many in the public sector and beyond have struggled to improve for a long time. It sits hand in hand with COVID, will be the second of our big priorities. Community and place is absolutely at the heart of driving improvements, so that warrants a place up there in terms of the 4 priorities, and poverty and children. And of course there are lots of links to be made across all of those. This is the very start of us setting out a new direction of travel, so that sets out our broad ambition and the areas where we will pay most attention over the next few years. But essentially, we will have a bigger focus on partnership working and a bigger focus on what difference we're making in improving outcomes. That will be at the heart of what we're trying to do. This is just a very quick slide to talk about how we define healthy place. Hopefully no surprise to you here that it's focused around the place standard and is a very broad definition of place, a simple tool to assess what makes for a good quality place, evidence-based, used by all local authorities and accredited by the World Health Organization, so has a lot of weight and underpins a lot of our work. We'll share the slides after the session, I'm sure. This just gives a very brief summary of some of the work that we've been involved in, and you'll see Matt and the team have had a big focus on demonstrable outcomes and achieving real change, and that's something we want to continue to build on over time. And finally, I just wanted to leave you with some thoughts on what we can bring. So I've said working together will be a critical part of how we want to deliver on the ambition. We all have the same ambition, we all have the same aims, and this slide sets out a little bit about what you can expect from Public Health Scotland. So a lot of support around guidance and evidence, a critical role in helping to influence policy at a local and national level. But critically, I think what I would like to see is much more involvement at a local level to help people address some of those real entrenched challenges that we're all facing. So tools and support, but absolutely being there with you on that journey, not something that we're trying to tackle separately from the centre in any way. We know that simply does not work. So tapping into and using your skills and experience to apply this will be absolutely essential to making this a success. So please speak to us, engage with us, and we can work together on improving place and the role that that has in terms of public health across the whole of Scotland. So I'll draw to a close there and hand back over to Irene. Thank you.
Thank you so much, Claire, for very concisely pulling together what is a very broad area and a very broad amount of work that Public Health Scotland have been given a brief to do, with then the brief really changing about a matter of weeks before it came into being, and yet I'm delighted that work is still progressing, because it is still seen as really important to have this feed into spatial planning and the role of spatial planning, and particularly the role of the National Planning Framework, because that's the next biggest change that we have ahead of us and an ability to shape. I think now, having just seen that final slide there of Claire's about, you know, how to start working together, it's perfect I'll just lead straight into Angela Scott's presentation. I was noting, I said earlier about Angela's close work with Gail Beattie in planning and involvement and awareness of the role of planning in place in delivering on health. And I was looking at your local development plan introduction, Angela, this morning, and it's absolutely perfect, because it does talk about, you know, the allocations and policies in this plan shape people's everyday lives and how they work, how they travel, how they shop, how they spend their leisure time, and that really encapsulates the thrust of what we're talking about this week. What are the processes we do to work more around that and to be aware of that, and what are the individual topics that later on in the week we go into around 20-minute neighbourhoods, active travel, housing, and the role of actual areas in a place in their contribution. So I shall hand over to yourself, Angela. I'm really looking forward to hearing what your CEO's conversion to planning. Great title, by the way. Thanks.
Thank you, Irene. Can you hear me okay?
Yes, we can.
Right, thank you, and good afternoon, colleagues. And it's certainly been a road to Damascus that I've experienced as Chief Executive, and I know the Chief Planner in Scottish Government recognises that I've been on that journey, and I guess to understand the professional discipline of planning. And so indulge me, if you will, for the next 10 minutes as I reveal to you what you already knew about the significant role that planners play in shaping the lives of people. And it's been a very kind of personal journey of learning for me as a chief executive. So I want to share with you, I guess, your own profession's history and how I've learned that history, and then what my kind of key moment in the road to Damascus and becoming a convert to planning. What was it that kind of shifted for me? And then, as Irene said, just the journey that Gail and I and some other colleagues that I'll reference as I go through this presentation have been on. So if I can work out the technology, please indulge me. I just wanted to spend a wee bit of time, I guess, looking at the past, and I think that's important because it's to understand actually public health is not new to local government. The creation of Public Health Scotland doesn't suddenly represent the start of public health. Public health has been a professional discipline, perhaps not recognised in that way, but as long as local government has been in existence. And in fact, much of local government's roots are rooted in trying to tackle the public health issues of the day. And if you take this image that's on the screen today, it's an image back to 1800s, and it shows the type of physical place that represented the world that we lived in. And endemic in here were the pandemics of their day, which were cholera, typhus, and smallpox. And they were killers in the 19th century, and they were largely the result of environmental pollution, poverty, and bad housing. And advances in the clinical model, the medical model, and as well as improvements in the social determinants of population health led to the eradication of those major killers that we would recognise back then. And worth just dwelling on the fact that in terms of what was local government's role in the eradication of those 19th century killers, and that's important to reflect on as we sit today in a different pandemic of a different route, as we think about what our future role is going to be in relation to health protection and public protection in particular. But again, if you go back in that history, there's significant pieces of legislation that conferred on what were described then as units of local government. So the Public Health Act of 1848, for example, made a state responsibility to act as the guarantor of standards of health and environmental quality, and the Act provided resources to local units of government, to make the changes to achieve those standards. The second significant piece of legislation in the 1800s also gave those same local government, those local units of government, the power to ensure that houses were connected to the main sewage system, and the Act forbid the building of new houses without such connection. Local authorities had the power to compel residents to connect their house to water supply. These were significant pieces of legislation which resulted in significant social change. And why was that? Well, fundamentally, the deadliness of cholera induced much of it. 50% of those who contracted cholera died. And cholera knew no social boundary, so actually it affected every single class of population in our country, and it really drove forward the response to address typhus. Just then looking forward to that history in the 1800s, those significant pieces of legislation still continue to shape local government as we would recognise it today. So, for example, that first bullet point there, we still have a registrar function, the function to record death. Now that its roots are entirely traceable back to those public health pieces of legislation back in the 1800s. So much of what local government does finds its roots back to the attempt to deal with public health and the social determinants of population health. So public health is not new to us, and it's not new to planning, but we're on a journey, and I'll talk a wee bit more about that. If we move to the present day, then I guess the major killers today are more the result of post-World War II affluence than they are poverty. And that's not to say that there are not conditions associated with poverty. But we would recognise obesity, alcoholism, smoking, drug addiction are all a result of increased higher standards of living. And they do and continue to have an adverse effect on health standards. In addition, many experts are attributing the COVID pandemic to climate change. And of course, climate change itself being a product of how we live today and how our economies are run as well. So linking the past to the present, the deadliness of cholera and the fact it struck all social classes brought about significant change that we saw in the 19th century. What will history show as the social change brought about by COVID-19, brought about by obesity, brought about by alcoholism, all of which are all striking at all social classes and indeed are bringing about death as well. So I'm going to whistle stop through these slides. You know all of these. You know the Health Challenge and Public Health Scotland have identified what are then the key public health priorities for Scotland, and that's well rehearsed. You know the economic growth challenges, they've become even more exacerbated in a post-COVID world around where will our growth come, which sectors will survive economically from the pandemic. You know our inclusive growth challenges, 5% most deprived data zones in Scotland are in Glasgow. Aberdeen and Perth containing none. So we have a continuing inclusive growth challenge across Scotland. And well rehearsed are our population challenges, an ageing population, and challenges about migration which become exacerbated potentially by Brexit too. All challenges that you'll be familiar with, and of course you'll be very familiar with the environmental challenge and the legislative target that we're in the process of being set by government to achieve net zero by 2045. So all challenges that you and I, heads of planning and chief executives, are all wrestling with all of these challenges that we're facing and attempting to tackle. So when did my road to Damascus happen? Well, I guess that for the first couple of years I was involved in loads of conversations and loads of different insight to different parts of the council and all that it was doing, and quite challenging to get a handle on all of that. I guess what I then tried to find was a way to capture all of it, and I discovered the social determinants of population health from public health, and it felt to me that all the issues, all the symptoms that we were dealing with could all be attributed back to these social determinants of health. And when you start to understand that model, actually you understand what a fundamental role that local government plays, far more than any other, I think, public institution in terms of the influence that we can bring to bear to all of these determinants of population health. So I guess I was trying to make sense of all of that. And then it coincided with kind of two things. I, like all chief executives, were trying to understand how we were going to change as an organisation to cope within our financial means. And like all councils, we started on a transformation journey. And as part of that journey, I changed the organisational structure, and I created an interim structure to allow us to kind of gently move through that structure. I was starting to understand the potential power of planning, but I wanted to lift the planning function up to be more than simply a regulatory function. I wanted to define it a bit differently, and so we created a post of Head of Strategic Place Planning, and delighted that BLPP holds that post. In addition, the city's economic growth continued to be important, so again it was important to retain that in our structure. The way it worked out, just because we were in an interim stage, those two posts reported directly to me as Chief Executive, which I guess on one level could be a bit unusual. But it was fascinating because it allowed me to start to understand, or attempt to understand planning. And so even though we're out of our interim structure and into our final structure, both Gail and Richard Sweeney both report to me as Chief Executive, and allowed me to start to understand the two functions. So I started to understand, or I think I do, the strategic regional spatial plan that we do. We're very fortunate with the collaboration that goes on between Aberdeen City and Aberdeenshire. So went on a journey of understanding our strategic regional spatial plan, and then into the process of and again, you guys will be much more familiar with all of this than me, but on the journey of how you develop a local spatial plan, and the role of the major issues report, which was hugely new to me, all the planning policies and all the guidance that sits with all of that. And I have to say, up to that point, all of that world had been completely out of my eye shot as a chief executive. And I think it's probably fair to say, probably out of the eye shot of a lot of people on our senior team as well. So as I was going through that journey, I was also going through the economic development journey as well, and trying to understand actually how effective were we being in the link between protecting the environment and supporting economic growth. And of course, Aberdeen's history, as you know, has been completely bedded on fossil fuel. So how were we reconciling that ambition and the need to transition that economy with what we were planning spatially as well. So 100 million questions from me. I'm sure it was tedious for colleagues, but just trying to understand those two things. And I guess the actual moment of Damascus came in addition to the work we were doing on planning, the strategic development plan, moving into our major issues, reporting into the LDP. At the same time, we were working on our biannual review of our local outcome improvement plan. And I guess, just as you say, as a novice in these areas, what I had in front of me were two very distinct strategic long-term plans, a LOIP for 10 years and an LDP with a potential for 10 years. And I just asked the question about how were we joining these two things up. how was the LDP in particular going to demonstrate its contribution to the outcomes that were sitting in our local outcome plan? And given our local outcome plan had been informed of significant strategic assessment of need, then for me it felt really important that the LDP was able to evidence that contribution. So that felt to me like quite a kind of moment of Damascus, asking the question, and interesting conversations with Gail at that time, who I think herself had been on a journey about understanding the levers that she had at her disposal as a fairly new head of planning. And so if I just move on to the next slide. So in the, I guess, the little gang that we had Gail as head of planning, then myself, and then the City Council's head of economic development, Richard. And then in addition, we were joined by Chris Littlejohn, who's the NHS Grampians Deputy Director of Public Health. Now, I'd been familiar with public health. I'd sat as a member of the UK National Institute of Health Research, the Public Health Committee. I'd also had exposure to public health when I'd sat as a non-exec member of a geographical health board. So I had a bit of an understanding about public health, but what I didn't know is how it sat in relation to planning. And again, really, really fortunate with Chris. He was willing to kind of come over an organisational boundary and join in these really exploratory conversations. And so I knew that public health understood the social determinants of population health, but perhaps I wasn't seeing them enough around the LDP. I wasn't seeing them around formally around the planning committee, but I knew the potential power that they offered. So we started, I guess, just in those joining up and linking colleagues, we started to professionally explore between Gail as head of planning and Chris as Deputy Director of Public Health and Richard as head of economic development. We started, and I guess sort of rediscovering the shared roots of both planning and public health. Back to, I think, that 1800 legislation, because essentially, I think when you go back to that legislation, what you see is then a health and all policies approach to population health. And essentially, that's what we're attempting to do. And as Irene said, through our LDP, we're trying to take a health and all policies approach, make sure that the spatial plan, make sure that the planning policies and all of the guidance, and then the decision-making process that's associated with the developmental control process, all the time tries to weigh up between the need to support economic growth, but to make sure that that economic growth is not harming our population's health or harming the ecology of the city at the same time. That all seems really straightforward, and we've crossed the line of stating that narrative in the LDP. We're now on the journey of going into the development control cycle. Colleagues in public health will work closely with Gail's team to review all the planning policies and to make sure that, again, we're putting as much emphasis on health as we can. This is not going to be easy territory because, of course, the members rightly have a democratic responsibility around planning, and we're going to have to take members on the journey. But we take confidence from Amsterdam, and if we look at Amsterdam just as an example in terms of their leadership, they are viewing childhood obesity as a health crisis. They're viewing it as seriously as we historically attached to cholera and to typhoid and so on. And they're using and they're applying their determination to use all the place-shaping powers of planning to tackle that health crisis. So again, you see in here examples about how they are planning to and how they are currently using their planning powers in order to tackle childhood obesity. So we know across the world that there are countries that are really actively using the power of planning in order to drive population health. And just in terms of reaching some conclusions, other audiences would be more familiar with the fictional character of Ebenezer Scrooge than the real-life character of Ebenezer Howard, who I know you will, as an audience, be much more familiar with. And as you know, he was a leading figure in the Garden City movement. He designed the new principles of town layout and architectural design. to create essentially what we're trying to do today, which is healthy environments for working population. So history, I think, is full of leadership examples where the powers of place planning have been used to improve public health. And our 21st century public health issues, climate change, global health pandemics, obesity, require us, the leaders in this century, to mirror the determination of our forefathers who improved health outcomes. Irene, thank you for that. I'm going to hand back to you now.
Thank you so much, Angela. You're taking me right back to first year at Dundee studying town planning with your Ebenezer references. Isn't it lovely to find that what you learned 30 odd years ago is still pertinent now? That's really encouraging for me, if not for many others on the call as well. I think there's a big aspect here about the determinants of public health. And just being clear about what they are, that they are defined as the conditions in which people live, work and play. It's as simple as that. And I don't think there's a planner on the call who would deny that that's what we need to be about right now. That's what planning has been pursuing for so many years anyway. And that the time is perhaps right to give them a little bit more teeth, so that the term I keep using, to be able to do that. So much of what you said, Angela, is about that process of pulling together. I wrote down coming over an organisational boundary. I like the picture of that and achieving that. This morning we had a session with the Minister and with the President of the RTPI, and the conversations around there came on to just how do we get people to work more closely together between local government specific to planning today and public health, and I noticed that we have a question in from Pamela Clifford, who's Head of Planning in West Dunbartonshire, about our views on having a public health officer part of a planning service, and how we could get something like that going and what you think around that. So I think there's a higher level for both of you about how do we get others in planning and health to speak more to each other. Is that by having secondments across, people moving across and getting to know it? Are there other means of achieving it? Be interested to know your thoughts on how we get that kind of whole system by using the practitioners and those with a passion in this area. Claire, I shall go to you first because we've already heard a little bit from Angela and are thinking of how she's done that in Aberdeen. Any thoughts from yourself, Claire, within Public Health Scotland?
Thanks, Irene. Brilliant question. I think for me, it is all about the practicalities of making this work and building the right relationships. So I think secondments is definitely something to think about. For us, in terms of our team, thinking about how we can get folk out into organisations, into different sectors to really understand the issues from a certain perspective. And as much as we can get focused on a local area, the better, I think. So that's my first thought is on that. But also just seizing the opportunities where we can start to apply some of the approaches that Angela and I have talked about. So rather than it being a kind of theoretical removed thing, you've got the plans and the systems in place. How do we all get stuck into that? So I would just encourage more of a public health focus in terms of planning. So building that in, as you suggest, Pamela, would be certainly something to think about. There are lots of people who can support you on that journey for sure, and that includes, but not exclusively, is us. So anything we can do to help around that, you need to let us know.
You.
Just a couple of. I mean, we propositioned Chris for a coffee, and then it just grew from there. And never have we had a conversation about Gail's team moving into Chris's team or Chris's team moving into Gail's team. What's been really powerful is the joint leadership, I think, from Gail and Chris, and their willingness to bring their teams together and to do that without kind of structural approach to that. And so I'm not sure it's necessarily about moving teams. I think it's just about that leadership from the heads. And actually, my reflection was Gail was incredibly generous around reaching into Chris and saying, help and bring your influence to bear on the LDP. And I thought that was really kind of professionally generous of her, and she did that out of an understanding, but equally Chris then willing to lean in, and that's what's, I think, has been the secret to us moving it forward. So rather than moving people or being slightly tokenistic about it, just to say the LDP is an LDP for the place. It's not owned by Gail, it's for the place. And if we're placed, then we all can pile into all of it. Ultimately, she carries the can to produce it. But I think that it's been more about, we've gained more because the engagement's been across all of Chris's team. And we're doing that as a council also with the health protection, and the COVID has accelerated that. The health protection, environmental health colleagues are doing the same thing. So I would slightly discourage you from going down the route of being tokenistic and having like one person in your team. Just bring your teams together all the time in a really joint way, and integrate your planning cycles together so that all of these documents, we co-design them together. The next challenge is going to be, and as head of planning, you guys know this, just then the decision making that goes on. So how do we bring health protection leads into the delegated decision making of Gail, and then how do we bring that voice into the committee itself? But I would encourage you to move as one as you can, and proposition them all to coffees and bring them into your team and really get to know every single one, because what we found is each consultant, public health consultant, brought a different specialism to then the conversation with Gail. So not one of them, like as planners, you've all got your areas of expertise. So go and find your DPH, go and find the deputy, and get having as many joint meetings. That we've gained a lot from that, Irene.
I think that's that balance between what's the local, and I noticed Margaret Douglas has a question in about where is the role for Public Health Scotland, where is the role for the local boards, and perhaps it is that get in touch with your local board. But if that local board is struggling to respond, then that's something for them to perhaps have a conversation also with Public Health Scotland around that. I don't know, what do you feel, Claire? Is that a sort of a fair way of reflecting how that sway could go? You're on mute. Sorry, Claire.
Explained by my chief. So just to say exactly as Angela's saying, one of the big lessons we've learned from COVID is just how flexible all of our teams have had to be. And when it's worked really, really well, there is a certain level of disrespecting boundaries. It's about focusing on what the issue is we're all trying to fix together. So I would definitely agree with that. Public health input comes from a range of different places depending on what the issue is. What we're trying to do and have done, and Matt and his team are just one example of it, is try and build up those really good, strong relationships. So nobody should be sitting there saying, well, where am I getting the public health advice from? There should be a strong and getting stronger network of folk who are able to support around all of that, because it is everybody's business. It doesn't sit off as some kind of expertise sitting in a corner. We've all got something to bring to this. So I think it is all about relationships. You should have contacts in Public Health Scotland, you should have good relationships with the NHS board connections and the like, and beyond all of that. So yeah, absolutely struck by that point about we're all in this together, very much so.
That we've all had in place for some time now, and the new planning act specifically asks local development plans to take account of those priorities in its vision, not just in a policy here or there, but in its entire vision. And certainly for myself, I go back to when I began at the Improvement Service. It was Colin Mayer wanting me to get local development plans to be the spatial iteration of the community plan of the LOIP, and that there's something so linked in then intrinsically when the public health reform came online as well. I notice we have a question from Maureen Chalmers asking about involving community planning partnerships and local communities. That's specific to yourself, Angela, but I will come to you as well, Claire. But first of all, Angela, can you share your thoughts on that?
Yeah, and thank you to Councillor Chalmers for the question, because it's absolutely critical, isn't it? With how you bring the and you'll be the same, Councillor Chalmers. You're trying to, on one level, plan for a whole area, and then within your area, you've got pockets that you've got to concentrate on because of inequality. So how I rationalise it, and kind of forgive the just layman perspective on some of this, I try to view the LOIP and the LDP as that city-wide kind of planning, bring those kind of big determinants of population health, and that we try and bring that together, and that then the decision making that sits underneath all of that from a development control cycle reinforces those public health. Underneath then the LOIP, we have our 3 locality plans, and again, you'll be familiar with the Community Planning Act that requires you to have those locality plans, as does your IGB, and then, as Irene says, now the Planning Act. So what we're now trying to do is, I think, we're trying to get the CPP, the IGBs, and the planning to now bring a level of locality planning. Now, that's all hugely cumbersome. But essentially, I think what we're trying to do is to bring those determinants of population health that we've identified in the LOIP and the things that we are doing together, and then bring them down into your locality level. So Gail has used quite extensively the place standard tool that Claire demonstrated earlier on to have some of that community engagement conversation. We've created 3 locality plans for our areas of worst deprivation, and we've tried to ensure that that as much as, of course, you want, the population and communities have to have a say in what's important to them, whilst we're also doing the bit around, well, we understand that if we could improve, I don't know, physical play for kids, then we could have an impact on childhood obesity, or if we could influence the licensing, the takeaways, the locations of them. If some of those are difficult issues, because communities, of course, want them, if they're on low incomes, that's affordable food. So what we're trying to do is, I think this is the next interesting step of the journey. We have community planning partnership boards at a locality level. We've had our first iterations of locality plans. We've been working through the place standard tool. And then I think now we're going to start to move a bit more pointed, I think, in that focus at the locality level as well. But I guess trying to get that balance between, us doing things to communities and communities trying to help them themselves. So I think maybe we've started the wrong way, but I just find all of this so bluntly complex that we're just trying to step. So if we could go from the city-wide level and get those determinants really positioned well, then we could start to work our way down. And then in return, coming back up, I think you're quite right about how do we then get community engagement. And of course, the Planning Act does say, start to move your delegation of decision making about what spatially gets agreed in an area over to communities. So we're going to have to wrestle with not only, I guess, the delegation from members to officers, but in turn that delegation from officers to community as well. And I wouldn't say that we've cracked that. We're on a massive journey around some of that. So linearly, in my mind, I'm kind of trying to go city-wide planning from a CPP and a city council, work our way down, but make sure that we're clear about those determinants coming their way down, and then in sequence and in parallel, try and do the community engagement back, and then see if we can try and connect the whole thing. But it's hugely complex. Since day one, I've always asked for the Director of Public Health to sit in the Community Planning Partnership. So again, and Gail, my Head of Planning, has always been one of the most constant members of my senior team that has embraced Community Planning Partnerships. So my advice is DPH needs to sit in your CPP, be an active member, and so does your head of planning. They need to sit in there so that they understand what else they can influence and who can influence the planning function as well. Sorry, that was a bit of a lengthy answer, Irene.
The journey that I have been on has always been around, as I say, spatial planning and community planning working together. And at times there's been a disconnect in understanding how the work of planning feeds into actually addressing many of the priorities that community planning and LOIPs have identified across Scotland. I think the work that Matt has been doing for years has sought to actually make that quite clear, that it is the interventions that we make when we're thinking about how people live and work and play that flow through as part of everything else into addressing public health. So that role of community planning has always been there. For myself, the public health reform has just helped to give it more of a focus into the why, because planning has always been about public health. Claire, what are your thoughts on the role of community planning as you're moving forward? Is that something that we still to sort of embrace and bottom out, but with a clear sort of vision that they're very intertwined, aren't they? The local outcome improvement priorities and the public health priorities. I think it's good. There's a lot of crossover. And you're on mute.
You know, sometimes it is a very complex system we're operating within, but I think it's getting closer to these things being aligned in a more helpful way. And I think for our part, they are your local communities. You know, we're not kind of coming in with a whole new, fresh approach to engaging with communities. That's local authorities are square in the middle of all of that. So our job is there to help support and feed into it where we can. But community planning partnerships will be an increasingly important bit of the work that we do. A lot of what we've done has pointed towards the health system, and I know that's not true of everything. There's a whole body of work that's gone on for a long time that Matt's been leading, which is great, and we want more of that. So that will be a big focus for us over the next few years for sure.
Within local health boards and within Public Health Scotland now that can inform local development plans. Any thoughts about what the priorities are for public health data and evidence and getting that through and across to inform? I'll go to Claire first and then to yourself, Angela.
Yeah, so it's long legacy to them. So we're going through a process as a new body of reviewing all of that to see what stays, what can go, and what's different that we need to turn our attentions to. Now we've got a clear strategic plan, so there'll be more on that coming soon. But again, that do sound like a bit like a broken record, but that will work best when we are engaging with a lot of local partners to see what they need. So there is more to do on this for sure. And we know there are big gaps in some areas as well. I was talking to one partnership a couple of years ago, and they had done a great job at integrating lots of different bits of data. And so I was kind of rubbing my hands thinking, this is what everybody's been waiting for. You know, we're in a great position now. You've got everything you could need. And they said, we don't know where to start. There's just so much stuff, it is impossible. So I think we've got a role to play in then helping to draw out what are the most important things for people. So more on that soon.
What was out there, and there is a need to begin with them deciding what are the questions that they're looking to answer. I think perhaps this is something, Angela, you and I have talked about, so I'll pass over to you.
Yeah, I mean, we've done a lot of work as a community planning partnership, and via Irene, I'll send all colleagues on the line the link to our website. I think there's health is incredibly data rich. It's not all useful, and local government has variation, and improvement service have been kind of really good in positioning to try and strengthen that. I think the key bit for me is evidence about what works. I think it shouldn't be on the wit of man for us to bring data sets together and join that up with the technology we've got access to, but I think we make hard work of that. For some of it legitimate reasons, some of it for non-legitimate reasons. I think the key thing as a partnership is understanding the research base, now either an academic research base or a practitioner evidence base. And again, I would say that local government disadvantages itself, or has been disadvantaged, because it doesn't have the access to research and evaluation that NHS colleagues in the NHS system has enjoyed. And that's why I went on to the National Institute of Health Research, who wants to shift the focus onto public health-led research rather than the medical model of treatment. Now, that's not to say that treatment is not important, but it's had a disproportionate amount of investment in it at the expense of public health-led research. As a local authority chief executive, I have not a jot of influence over the research that two university academic institutions that sit in the city have. I have no influence over whatsoever. I have no influence over the research that gets commissioned through the Scottish Funding Council or any of the UK bodies, and yet I have no research body to go to. So what we elected to do in trying to navigate that world as a partnership, we've created a platform bringing data sets together, trying to create a window to the world of research so that any of our practitioners on any outcome, whether it's planning colleagues or a teacher in a school, that we can give them easy access to the research community in both academic research but also the applied. And for me, that's where the improvement service is growing in its strength, around being able to show us in our family structure of similar partnerships what practice they've been doing and experimenting with. So the data is an important journey to go through, but the stronger journey is to get into understanding that research academically and across the UK and across the world, and both academic research and applied and practitioner research, and an ability to access the evaluation of that. So, you know, all partnerships are doing lots of experimentation, but there's not an agreed approach to how we evaluate that and then how we share it. And I think IS has started to try and get into some of that space. So the data is important, but it's the evidence about what works, and more importantly, what doesn't work, and what then as a partnership you should absolutely avoid. And then there are just some things that are just do it. So I'm on the National Suicide Leadership Group. It's clear that when you take suicide as an outcome, every area in Scotland has a hotspot where historically folk have gone to attempt suicide. It's a no-brainer that you should have measures in place. There's not a massive global research evidence base to support that, but it's just something that you should just do. So I think the strength potentially for Public Health Scotland is to become that coordinator or that overseer of that research and to disseminate it, because we just don't have the resource at a local level to track all of that research. I think if Public Health Scotland can be in that position of overseeing that research, disseminating it, and with organisations like Improvement Service, bringing us together in collaboratives of learning, in the way that Scottish Government have previously on some of the children. I think that stuff is absolutely terrific. Bringing us together in order to share that evidence and that evaluation, I think that will be a formidable contribution if Public Health Scotland as an institution can help the public health system of all of us who are public health experts. And I'm very clear, my head teachers and my school teachers are public health generalists and specialists. They've set a different set of professional exams than public health consultants, but that doesn't make them any less public health specialists. And I think planners are a formidable group of public health specialists as part of that. So I would go beyond data, Irene, and I would go into the research base and how we can access, and I hope that Public Health Scotland can play a strong role in that.
At the beginning, Claire, you referred to the work that Matt Lowther is doing to feed into that. What is that big role then, as that being the next bit of national support? Very quickly, what do you see there being as an opportunity for that national planning framework to support this moving forward? Claire, I'll go to you first and then Angela.
Thanks, Irene. So I think we've already just as Angela said, what works, what doesn't work. I think a lot of good partnership working, but the next step will be connecting all of that up in a way that really prioritises a focus on Scotland where everybody thrives. So what I want to see for us as an organisation over the next few months is a much clearer sense of what difference all of this is making. And some of that is a generational change, but we need to pay a lot more attention to how outcomes are improving, what is having the biggest impact, and how do we do more of that in partnership.
I said all this to John Tierney. The National Planning Framework, and this is music to Margaret Douglas's ear, must adopt a health in all policies approach. So he must reflect that in the National Planning Framework. He must reflect that in all the planning policies and guidance that are issued from government. And then when we go into the development control cycle at a local level and the right to appeal that goes back into government, John must enforce and validate any decisions we make at a local level that go in favour of population health. So the appeal system that government are then responsible must absolutely reinforce what we're doing. So health in all policies approach to the NP4 and into planning policies and guidance and then into the appeal system.